Hi, my name is Andrea, and I'm a training and education developer at Heartland National TB Center. Today, I'm with Dr. Barbara Seaworth. She's the medical director here at Heartland National TB Center. And today, we're going to be talking to you about a rapid communication the WHO recently came out with on the key changes to treat multi-drug resistant tuberculosis. Hi, Dr. Seaworth. How are you?
Good morning.
Thank you for being here. So today you're going to tell us a little bit about the key changes that recently came out in the rapid communication that the WHO came out with on treating multi-drug resistant tuberculosis.
Thank you for this opportunity. Yes, I was very excited to see the communication by the WHO. The full guidelines will follow sometime later this year in 2018, but they felt that this was important and that they wanted to get this information out now so that providers and programs could begin to make changes. And they very much emphasized the fact that they have identified new evidence from more than 12,000 patients, 50 good studies in 26 new countries around the globe that contributed to this scientific base of information, leading them to make these new changes. And they didn't want to wait until the publication came out later this year. They wanted programs and providers to begin to act now on these new changes.
Yeah, and can you tell us a little bit about what the guidelines mean for patients in particular who are diagnosed with multi-drug resistant TB?
So currently, the treatment for MDR-TB is long, difficult, hard, painful. Patients have to tolerate many toxic drugs during their treatment time, including oftentimes having between 6 to 12 months of a drug that's given either intravenously or by injection. And around the world, and even in the US and in Texas, that means for many patients, unless they're in the hospital, that they get an injection daily, 3 to 5 days a week. And these injections are painful and very difficult. And on top of it, the medicine, although effective, is associated with several very significant toxicities, including hearing loss, which may progress even after the patient has the drug stopped, and the potential for loss of kidney function. So very, very difficult drug to take. And this drug, which used to be one of the key drugs in the initial phase, at least, of MDR treatment, has now been suggested as an alternative drug when other oral drugs cannot be given. And so that's very exciting for patients. It'll make a big difference. It'll be easier for them to return to work. And the new drugs that are replacing these drugs are as effective, many of them more effective, and definitely less toxic. So this is a good thing for patients.
Yeah, it sounds like a very positive update. And can you also tell us a little bit about in this communication how they talk about the patient involvement and their choice in their treatment? Can you address that a little bit?
So patient-centered care has been an important cornerstone of recommendations from both the World Health Organization and the CDC for a number of years, but WHO is now really stressing that patients need to be very involved in their treatment. They need to have counseling regarding the disease itself and the treatment regimens. They note that the importance of noting to the patient these new changes and how that would affect the effectiveness and toxicity of their regimen. They note that we should be providing means to allow the patients to adhere to their regimens, including a wide variety of social support mechanisms so that patients can be focused on getting their treatment and not how they're going to feed their family or other concerns. And then lastly, that they really are now stressing the importance of toxicity monitoring, and that if patients are exhibiting toxicity or intolerance to a medication, that their options in treatment should be should be changed to make it easier, or another drug substituted to hopefully provide an easier way for the patient to achieve treatment success.
So it sounds like there could be a lot of positive changes coming for the patient, especially in terms of the medication that they have to take. Do you mind describing some of the new medication regimens that this communication details?
Sure. The WHO now has 3 categories of medications: Group A, Group B, and Group C. And starting with Group A, they're recommending 3 drugs that should always be given unless there's a specific reason that the patient cannot tolerate this drug, or perhaps the patient is resistant to the drug, or there's an important drug-drug interaction with another medicine that the patient definitely needs. But these 3 drugs include either levofloxacin or moxifloxacin, bedaquiline, and linezolid. And bedaquiline is a drug that's really been substituted in, especially to replace the second-line injectable or IV agent. Then Group B includes 2 oral drugs that also have good efficacy, maybe not to the level of the Group A drugs, but also have reasonable tolerability and safety. And those include cycloserine and clofazimine. So notice that all 5 of these are oral drugs. There are fewer drugs that actually need to be taken, so fewer numbers of tablets. And most of these drugs can be taken as a one-time dose, all together at one time during the day. So that would allow the patient then to go on for the rest of the day, go to work, take care of their children. Also, these drugs are less likely to cause the severe nausea and vomiting than some of the other Group C drugs that have been moved back. And we're really only going to give those drugs if patients can't tolerate these frontline drugs or they're resistant to one of them. And so drugs that have been moved back into Group C drugs include ethambutol, PZA, ethionamide, the amikacin, and PAS. So these are all drugs that previously were part of the standard building blocks of the MDR regimen, and now they're kind of Group C. Use only if you can't use the good drugs. And so we're looking forward to these changes, and I believe patients are looking forward to them. And I know if I ever were treated for MDR-TB, I would want this regimen. I would not want the Group C drugs. If my child had to be treated for MDR-TB, I would stand on a stool and demand these good drugs. And so I think we should do the same for our patients.
Absolutely. Well, as you said, the full guidelines will be out later this year, but as of right now, the rapid communication is out online. If you'd like to check it out, we'll include it in a link in this video. Dr. Seward, thank you so much for talking with us.
Thank you.
I think that this chat has definitely been very informative for everyone watching. I know I learned a little bit or a lot. And look forward to the full guidelines later this year.
Okay, and I just want to note that one last thing, that the purpose of this rapid communication was they urge programs to not wait, to start making the changes now, to not use up old stocks of drugs just so they could use up their stockpiles, but to immediately begin to place patients on these new regimens and to notify patients who are on old regimens of these changes and the implications of remaining on their older regimens, or the possibility of changing to a new regimen. So they are very serious about this new treatment for MDR-TB, which is a good thing.
Very good thing. All right, well, thank you. Y'all have a wonderful day.
Thank you.